to Healing Minds. Today, I am honored to speak with Dr. Roger McFillin, a clinical psychologist and outspoken advocate for evidence-based mental health care. He has over 20 years of experience in the field. He's known for his clinical approach to mainstream psychiatric treatments, particularly SSRIs and their long-term effects. Dr. McFillin shares his expert insights on what the research says, the risks of SSRIs, and alternative approaches to healing. You won't want to miss this. Hi, Dr. McFillin. Thank you for joining me here on Two Healing Minds. I really appreciate it.
Thank you. It's an honor to be here.
Yes. So why do you think SSRIs are harmful for adults with depression? Remember, we're just talking about adults here, not kids. And also, the second part is, do you think it depends on the specific SSRI, the dosage, or do you see this as an issue just with all medications as a whole?
Okay, well, let's start with the first question. So I think your first question is, why do I see them harmful?
Yes, for
Okay, so
adults.
I generally don't like to speak about these things in such binary terms, but let's just stick with facts. These are established scientific facts. These drugs have pretty significant drug effects to them that can be potentially fatal or potentially permanent. So we know that there's over 40 international drug regulatory warnings on increased rates of violence and suicide for the drugs. There's at least a double the risk of when you take the drug of becoming suicidal or violent. They're well known to have stimulating effects from mania to psychosis. The most common drug effect for SSRIs is what's called emotional blunting. Now, emotional blunting, which can be viewed for some people as potentially therapeutic if they're in a struggle with intense emotions and they don't feel them to the same intensity, I'm going to describe that as a short-term reaction with potential long-term consequences. The concern I have about emotional blunting is it also blunts positive emotions such as joy, feelings of like excitement, anything that we would identify as positive. And there's also a condition called post-SSRI sexual dysfunction. So one of the harmful drug effects is that it also mutes or blunts libido, one's ability to have an orgasm, and it's potentially permanent. So this is a drug that is known to induce that side effect. And even when people get off the drug, they still experience a lifelong condition of no longer able to achieve orgasm and a decrease in those positive feelings of joy, as well as sexuality. And so it's a dangerous drug because we can't predict who that's going to affect. And we haphazardly prescribe that drug to young people. And informed consent, which is a legal and ethical imperative, is to inform the individual that these are the potential risks of taking this drug, to respect their individual authority, autonomy to take the drug, and then to present alternatives to what they're struggling with. And those alternatives are, again, part of informed consent process, and that doesn't occur in the United States. And so that's what I'm outspoken against, not only the harms, but the limitations that we've put on people by not providing them adequate informed consent. And much of what SSRIs are a narrative that's been sold to the American public, not science. And so I want to speak out about the science.
Okay, and also, I'm just wondering, because I know with SSRIs, dosage has to be taken into consideration. Like with some medications, it's 10 milligrams and it can go up to 40. So do you see there's like less harm if you're on a lower dosage, like a 10 milligram as opposed to a 40 milligram? So it really has to do with the particular SSRI, how much is given to the patient. Maybe there's not any harm at like a 10 milligram dosage compared to higher. I mean, that's something that I was thinking about too, considering. Could that be a possibility?
Well, the thing that's really important to state here, and is to be responsible around this, is that um, drugs affect people differently. And
Yes.
for some people, a low dose of inducing any drug could have permanent and fatal responses to it. So to say that there's some established efficacy and safety around a particular dose
Mhm.
or a particular drug that's an SSRI would be false and misleading. And I don't want to mislead the public by ever making such a claim. I don't know if there's fundamental differences. SSRIs are SSRIs. When we
Mhm.
target the serotogenic system, and induce serotonin, there is consequences to that. We can't even begin to understand the complexity of the human mind and the human body. When you induce a change in one aspect of the body, you're altering the effect of the entire body. And the biggest problem with these drugs is they haven't been studied long term. And there's good reason to not study these long term because then you don't have to report on the harms. You
Mhm.
know, 8 weeks clinical trials is not sufficient. And
No.
even the NIH funded, trials for both adults and children that extended beyond a year, we saw just horrific outcomes, poor efficacy, and significant safety data concerns.
Yeah, you're definitely right about that. I mean, it's 2 months is definitely not enough data to see if there's a potential harm of a medication. Most people are on it for at least 6 months to a year. Some of them, I think it says you won't feel the effects until 2 months, a month or 2 months before you
No,
actually feel it's working for you. Is that true? Or
no, those are lies. It's propaganda that comes from the pharmaceutical companies. Listen, their
Mhm.
job, they are beholden to their shareholders. So their pharmaceutical salespeople are trying to get as many people as possible on those drugs for as long as possible. To do that, they've had to influence the general practitioner on prescribing practices. And they've created their own marketing agendas to be able to really provide these doctors a some talking points on the patients who take the drug and don't experience anything, or either depression doesn't resolve itself, or worse, that they feel worse. And so they've really convinced doctors, and there's many funding efforts through major medical organizations to try to influence the prescribing practices through protocols and medical recommendations. And so a lot of this, again, it's marketing propaganda, it's not science. And so drugs affect people differently. Some people are going to have an effect from the first week on it. It's going to affect them in some regard. Some of those can be potentially permanent and fatal. And for others, they don't really experience any difference on the drug at all. They don't even notice a difference. And then they attribute any changes in their lives to the fact that they took the drug. It's massively overprescribed in such dangerous ways. And there's a legitimate scientific debate on whether they have any value at all.
Mhm. Yeah, that's interesting. I mean, I could continue on this, but I want to get on to other questions about the dosage. There were some studies, like if it was at 60 milligram, it was so dangerous, so they had to put a law against offering at past the 40 milligram. I don't want to talk about the names of the medications, but just to get on with this topics is like, for instance, if you have individuals that are dealing with suicidal ideation before being on drugs, or a recent suicide attempt, can an SSRI still play a stabilizing role in their recovery? And and this is just, temporary until they become resilient by learning other therapeutic approaches to help their depression. Perhaps they're not in therapy. They're just like, gosh, I haven't even started. I don't know what to do. Can I use the medication just to kind of give me that strength or something while I'm going through this suicidal ideation, while I go through therapy and learn alternative approaches? Do you think in those instances?
Well, let me correct you. First of all, these aren't medicine, right? Medicine
Mhm.
comes from the word medicinal, and
Okay.
medicinal is health promoting. It could be correcting an abnormality. And so I think we have to be careful of how we use the word medicine. So certainly
Mhm.
I'm not going to support that it's medicine. And there's really nothing that you stated is grounded in any science. I don't even think it's grounded in any like logic, to be honest with you. Why do people kill themselves? Like, let's ask ourselves the question, why do people want to die? They die because they often are dealing with pretty intense hopelessness. They believe that they're in pain. They might believe they have no value, and they don't see it getting any better. So it's that hopelessness that drives them to want to end their life, because we are extremely resilient people. We can deal with
Mhm.
pain when we know it's short term. Most of us accept that life is hard. And as long as we view those situations as something that are surmountable, that we can overcome, it really protects us from this notion of suicide. When people become suicidal, it is really about intense hopelessness. So Um, I can't, from a scientific standpoint or a medical ethics perspective, in any way argue for why we would provide a drug that has been proven to induce suicide as a suicidal intervention.
Mhm.
No one can
Okay,
really answer that
interesting.
question, so maybe you can answer it for me. Why would we provide a drug that induces suicide to somebody who's already vulnerable and experiencing suicidal ideation?
Well, that's interesting. I mean, that's a very, very touchy and hard question to respond to because, like, for instance, if somebody is suicidal, they might seek help from a psychiatrist. That might be the first place that they go. Like, hey, oh, I'm having this suicidal ideation and it won't go away. So the first place that they go is to a psychiatrist. And what is a psychiatrist going to do? You're here to see me. Obviously, I'm going to have to give you a medication somehow to stabilize you. You're having these hard emotions, maybe something to kind of bring down those emotions a bit. And other medications, I don't want to
So
go into
yeah,
I don't
so
want to
you would
go into benzodiazepines or anything, but
so
we need
wait,
to
but you're
but I
arguing.
understand what you're saying also because there are those side effects of I don't know if
So
it's S.
so Tanya,
Okay, go ahead.
yeah, let me intervene here. First, when someone's suicidal, the first line of intervention tends not to be a psychiatrist. So that's usually not the first intervention when someone's suicidal. It's usually, family members they're talking to, it's friends. It could be a primary care physician. You're usually outside of the system, but if you are in getting therapy, then it's going to be with your therapist. You're when you use the word stabilizing, you're assuming that a person is going to is more likely to become suicidal or end their life if they have an intensity of emotions. And that tends to only be the case when we see impulsivity. So when somebody has severe emotion dysregulation and they're very reactive and they don't have the ability to maybe regulate the emotions and then they have the means to do so, those are where there's a higher likelihood of a suicide event. The chronically depressed person, kind of where we're referring to, it's no one kind of sees like suicidal thoughts are something that come to us and they don't go away. They're part of the person, they're part of the individual in the way that they see the world and the way they see themselves. So you're speaking to the inner workings of a person's mind, and there's context to this. There's reasons why they became suicidal. It doesn't come out of the blue. It's not like you obtained it like some a virus. It's not outside of you. It's not a disease state. It's within you. It's within the person in context of legitimate problems that exist in that person's life. Work with suicidal clients my entire career. I've never met somebody who described becoming suicidal out of the blue for no reason other than it occurring on a drug. Like
Hmm.
these are real legitimate concerns. There are people who take drugs, not just psychiatric drugs, other drugs, and they feel like there's these voices or these things that occur outside of them. That's a clear drug reaction. It's happened in my career from clients being on a range of drugs, but we see it most frequently when someone is not experiencing suicidality. They're not suicidal. They might be struggling with their emotions. They might be depressed. They might be anxious. And then they're provided an intervention, and then something is fundamentally shifted within them. So this is more about suicidal intervention and literacy of a conversation. So to say you can just go take a pill and that somehow stabilizes you, or you don't have these thoughts, or it decreases your intensity of emotion, and that opens you up to becoming more resilient, is certainly a misnomer. I mean, that's not accurate at all.
Okay, interesting. I mean, I don't want to bring up personal experience, but yeah, that almost sounds like personal experience because you were saying, because I've gone through clinical depression, I've pretty much stabilized and everything. And if I look back a few years ago when I first knew I had this without taking any medication, I wasn't on zero medication and I had suicidal ideation. It was so intense for 6 months without getting help from anyone. I came to the determination on my own is, hey, I need to see a psychiatrist for the first time in my life. I don't know how I came to that determination, but I did it on my own. I said, okay, I'm going to need to call one. And the first thing he did because I explained, as you said, it is events. It's not just like out of the blue, it has to do with a lot of heavy events. And of course, the first thing he does for me is prescribes an SSRI to build, like as you said, resilience, like to use this as a tool while you're working on your issues. And as you said, that's what are. That's how the approach, it shouldn't be. Like,
Yeah, that's
I
the,
remember he said this is a tool for you to use
yeah, it's a very
while
hard
going through this.
it's a very harmful narrative, and it's antithetical to what resilience is. No one would say, we build resilience by looking for a substance or looking for a drug to deal with our
Hmm.
internal experience. In fact, we would say that's part of the problem that exists in this mental health and chronic disease epidemic that exists in the United States, that we're always turning outward for something that's experienced inward. Resilience would be, hey, you can get through this. This is painful, but it's painful for a reason. There's things in your life that you certainly have to address, right? We can't talk about harmful pharmaceuticals, chemical compounds made in a factory that we haven't studied long term, as something that's a tool without telling you, hey, this very tool can make your experience much worse. It can increase the chronicity of depression. It could increase the likelihood that you might want to die. There's potential chronic health effects. There's potentially permanent sexual dysfunction that's associated with it. No one kind of would say that's a tool. That's a concern, right? And we're not going to talk about it in terms of building resilience. It's the opposite. I'm a clinical psychologist, and when I work with people, if they're turning to, alcohol, cannabis, benzodiazepines, SSRIs, whatever it would be, it's all a same class of understanding, is that I'm trying to change and alter the way I think and feel. And I somehow believe that's going to provide a positive outcome for me where I'll be able to overcome this. And we have no evidence to support that. In fact, all the evidence would suggest it's quite the opposite. Since we've started widely prescribing these drugs and really became a drug-based culture off of false narratives, every available statistic is going to show that we have more people depressed, more people anxious, even longer, more people disabled by mental health conditions. So, I'm taking in a very kind of a reasonable and common sense approach to talking about mental health. Is there has to be a change of the narrative. It's the narrative that in itself that is creating more problems. The actual interventions and treatments are creating more problems.
Okay, and so do you even suggest antidepressants are completely harmful, even in the short term?
We have no drug that's antidepressant. It's never been
Oh,
proven.
oh,
So
yeah, yeah.
it's a,
I
it's a,
forgot that you're not for that name. There's no such
it's a,
thing.
no, there's no such thing, Tanya. It's a marketing term.
Yes.
We have to be scientific in this. So we have no drugs that have been proven to be antidepressant. Okay, so we have SSRIs, and no, there's no evidence that the short-term use of an SSRI outperforms a placebo in any clinically relevant way. So there's things that you're talking about that are relevant. So if a person actually believes that there is something broken within them, like I have a genetic condition that increases my vulnerability to depression, and I believe in the United States medical system. You put them in a clinical trial and you give them a placebo, not even the active agent, there's going to be measurable change.
Hmm.
And I think that's around expectancy effects. Now, this is why science is so important, why it needs to be evolving, why we need to evaluate, why we need to have critical thinking about scientific data. No one can say that trials of SSRIs demonstrate that they clinically outperform other interventions, even placebo based interventions. But yet the risks are quite significant. So we have to be weighing the pros and cons of any medical decision. And when we weigh the pros and cons and we see that there are potentially fatal and permanent adverse reactions to the drug, in no means can an ethical clinician recommend that, because there are other alternatives that are safer and more effective.
Okay. Hmm. Yeah. As I said, this is such a complex topic. But okay, so if there's no scientific evidence to support the idea of serotonin or chemical imbalances of, like, let's say, clinical depression, I know there's been studies of SSRIs, as you said. It's not effective, whether you take it or not, it doesn't make a difference. But there are other illnesses like Parkinson's disease that has to do with a chemical imbalance like dopamine levels. There's hypothyroidism linked to hormonal imbalances. And so those are directly related to chemical imbalances. So how do you explain the difference? Why wouldn't there be a chemical? Like, for instance, if you're like severely depressed, you're saying that that's not going to be decreasing your serotonin levels because you're just not feeling just good or just really bad. And so your levels are decreasing. So you don't believe in something like that.
It's not necessarily about my belief. It's what we know
Oh,
right
what
now.
you
Okay.
know.
So there's some false comparisons you're making. So Parkinson's disease, for example, and by no means am I an expert in Parkinson's disease, is an established and identified medical illness that we can evaluate and test for. And there's motor dysfunction with that. And there's a range of drugs that they prescribe to try to manage the systems. It's a degenerative condition that we don't have a cure for, and we don't even understand its origins. We know that when there's traumatic brain injury, like for, combat sport participants, for example, that increases the likelihood. There could be potentially some, genetic variable that exists. But what you're doing is you're talking about the difference between us prescribing a drug to try to decrease symptoms like of, motor dysfunction versus a narrative that reduces a biopsychosocial condition like depression to one neurochemical. Now, first of all, it's debunked. It was never established. So it's interesting that here in 2025 we're actually still having a conversation about it, as if it was ever a valid understanding of what depression is. It's really important to understand historically. In 1968, there was a book titled The Epidemiology of Depression, Charlotte Silverman. And in the book, it's identified through community-based surveys, epidemiology, that fewer than 1 in 1,000 adults ever experienced clinical depression annually. All right, that's throughout the 1930s, the 1940s, and it was nearly absent in children. Right? So this is a very rare condition traditionally. That we're in a time where we identify with depression as a disease that is more of an umbrella term from any adverse or negative reaction of the human experience. That's a big shift in how we think about what it means to be human and go through a lifespan. In order to get more people to identify with depression, what has happened is they've just created a criteria that increases the amount of people who identify it, right? So, for example, like right now, just 2 weeks of experiencing, depressed mood, sleep problems, irritability, you only need like 5 symptoms. You can meet the diagnostic criteria for clinical
Hmm.
depression. So we've increased the amount of people who will identify with it, which increases the amount of people who go for treatment. The truth of the matter is the most severe of depressions, which is real, it's been accounted for throughout history, is quite rare. And it's really important that we understand that how do we help those people? What is most effective for those people? And stop with the rhetoric that exists right now in 2025, where we get people identifying with clinical depression during any difficult and challenging time in their life. Now, what makes right now modern life a little bit different is that, yes, we've increased the susceptibility for feeling sick mentally and physically, right? There is a disconnection with how we were designed to live and modern life. So people feel bad when they feel sick physically. The more you get disconnected from nature, the more you socially isolate. There's a number of other chronic health conditions that also have the symptoms of depressed mood or low mood. If our sleep is impacted, anyone who's had trouble sleeping understands how that affects their mood the next day. And now we've created this umbrella term and say you're just depressed if you experience any of that. So we're not really dealing with the root causes of why somebody is actually feeling miserable. Traditionally speaking, clinical depression is a disease of despair. It is part of the challenges of being a human being that certainly we can increase the likelihood that someone feels really in despair by conditions of like loss or abuse or poverty or failure. Life is painful. Life is painful for everyone, even if you are not subjected to trauma or poverty or a number of these other factors that increase the susceptibility of depression. In some ways, it's like a categorical error. We're trying to make it into a medical condition. The reason you make it into a medical condition is because then you can get a drug approved for it and you can create an industry around it. And we have done all of those things. Well, what are the outcomes? Is there less depression? Do we have better outcomes? Is it shorter? Are people more resilient, stronger, healthier? No, it's quite the opposite because we're in a sick care system. And in that sick
Mhm.
care system, we are actually prescribing interventions and intervening in ways that are going to increase the likelihood that person stays chronically sick.
Yeah, but no, I understand what you're saying is it's almost like you're talking about people. I believe there's three levels. There's mild, moderate, and severe depression. Like you tend to talk a lot about people that sound like they have mild depression, and I don't
Not
believe
true at all.
they
Not true at
should
all.
not be on medication. If you're just like going through like, hey, I'm just having a stressful day and I'm just no, those people should not take an antidepressant. I'm talking about like the severe, like it's been
Tanya,
going on for months and it's just like,
So, Tanya, you're referring to what traditionally we may see as
uh-huh,
um, a more impairing and severe depression. What's
okay.
happening is, first of all, antidepressants are being prescribed, SSRIs are being prescribed across the spectrum for loss, for normal life events,
Mm-mm,
for gastrointestinal problems, for PMS. I mean, we can go on and on and on. So if there was an antidepressant drug for the most severe depression, I'd support it. Right. I think
mm-hmm,
if someone is really struggling, impaired, they're not working, they want to die, then yeah, whatever's available, help them out. Like I would support that. I'm not speaking to mild and moderate depression. I don't even work with mild to moderate depression. I don't even take those cases on. I work with people who are chronically suicidal, who sometimes have been identifying under this umbrella of depression for not just 6 months, but for like years and
mm-hmm.
are inappropriately treated. And we don't have drugs that help them. It doesn't exist. If we
Okay.
did, we wouldn't have the problem. Now there's ways to intervene with people that are successful. I mean, there's so many ranges of options, but ultimately what it comes down to is that that person deeply believes that there's something broken about them. Get into the minds of somebody who is depressed and they learned it somewhere, Tanya.
Mm-hmm.
They've learned it somewhere and they're caught in that inner world that they are somehow don't have value, um, that they're only going to be rejected, that nothing's going to work out for them. And it's impacted every aspect of their lives. They've socially isolated. It probably changes the way they eat, the way they sleep. There's so many factors. So that means that there's lots of opportunity for intervention. But the most important piece is to see people of value, to see them as not broken, to see them as somebody who has the ability to transform through this because there's a reason they got depressed. And the reason they got depressed is not because of some made up chemical imbalance in their mind. They
Mm-mm,
got they got depressed because legitimate life events have happened. Some of them have been horrific. Some of them are unspeakable traumas, unspeakable events. You know, the way that some children are treated, um, survivors of abuse, neglect, a number of things. Obviously, by the time that person begins to mature, it's very difficult for them to see themselves as somebody who is lovable. So there's so many challenges, and when you start reducing the entire complexity of the human experience to one brain chemical that we don't even fully understand, is then you're also invalidating those real legitimate experiences of the people who've gone through that. And I think where we have our best success is that you know that those people have the ability to transform and overcome that when they're in environments of people who love them and when they fully believe that they can change their lives, that they maybe that they're not responsible for the things that have happened to them, but they take full accountability and responsible for their lives now in an environment that promotes optimism and belief in who they are and that they can get through it. Because obviously we do. We see people get through depressive episodes and they're changed for the better because of it. They become more resilient. They're strong. They themselves understand that there are reasons they went through that and they find purpose and meaning in that. And so it was just dumbing down the conversation by saying that's going to be solved with a pill.
Mhm. No, no, absolutely not. I've shared that before. I said that there's no magic pill. That's not the answer. And I do believe it should complement therapy also, not just medication. It should be a combination of medication and therapy for the
I dis I
severe.
I disagree with that. There's no
Okay,
evidence that, yeah, that's again just more talking points. It's not like you combine the two and we have better outcomes. Therapy is one option.
for the severe cases. Remember, my belief is mild because I could tell the difference. I've been through all stages, and I would say no to myself. If you have mild or moderate, you deal with your life problems and you move forward. But when I got to severe, I mean, I just decided that for me, that was the best option because I had nothing to lose when you get to that point. But I do agree with you. If somebody's just going through, oh, just a life event, get over that, it's just a mild depression.
No,
I don't advocate
yeah,
medication.
everything starts with a life event, right? And
Yes.
everything starts mild at one point until it becomes moderate, until it becomes severe. So what we're seeing is how the person responds to those life events is what really is going to encourage whether that person moves through it or that person gets stuck in it. So again, listen, I'm very, very clear. We have no evidence that if someone identifies with a severe depression, that there's a drug that helps them. We don't have evidence that combining therapy and medication somehow improve that outcome. And then we're also just limiting the available options to just two. Like, what the only way that someone can overcome depression is if they go see a psychiatrist or their primary care, swallow a pill and see a therapist. I mean, that's ridiculous. I mean, a lot of people who overcome depression never even enter into the system. Maybe it could be their church, it could be their family, it could be other community-based resources where they find purpose, where they find meaning. Now, certainly therapy is an option, and therapy can be effective, and a lot of people need that time to with a professional to kind of look within and face what's going on with them and enter into treatments that actually do show efficacy. Even right now, um, uh, integrating into like nutritional therapies and changes in lifestyle, right? Have a tremendous effect on how somebody feels, right? And can give them this ounce of hope. Entering into, communities where they're actually like-minded people who are, dedicated to their health. If they see themselves as an entire whole being of physical, mental, and spiritual, like there's all these other options when we talk about how do you overcome a difficult time in your life, even if it's severe depression. I mean, I would say severe depression is when someone does want to die and they have a hard time getting out of their bed, but it doesn't mean they can't get out of their bed. And we have to be careful about how we frame it because we're making them passive participants in their own life's journey. Right? So listen, it's available option, right? And it's been available for 40 years to go on SSRIs, right? Everyone has that availability, right? My responsibility here is to be clear with people that don't think that solution comes with a pill. It never has and it won't, right? That's just not accurate. And we have to be more responsible in how we communicate about this. And the reason why I have such a reaction to what you said is because we have therapists across the country who are recommending SSRIs. They know nothing about the background, the history, what it does medically. They're just buying into the narrative. They were told, which is not true, that if you combine an SSRI with a therapy like a cognitive behavioral therapy, that's the most effective outcomes. So they're
Mhm.
passively absorbing that information and then repeating it and putting a lot of people in dangerous situations.
Okay, okay, interesting. Like I believe primary physicians, they don't have the knowledge or experience, and they shouldn't be prescribing any psychiatric medications. And one should always get help from a psychiatrist. Do you agree with that?
I think both have been proven to be harmful under today's model. So, yes, the primary care physician, I think 80% of psychiatric drugs have been prescribed in primary care and are fueling the epidemic that exists. But the drug harms are the drug harms, so it doesn't matter who's prescribing it. When there's drug harms from SSRIs, and I think I've been clear on your show today that we don't have really good safety data nor efficacy data to suggest they're useful at all. If we're just talking about SSRIs, I surely don't think that primary care doctors should be prescribing them. And if we stopped immediately having them prescribed in primary care, we would see the health of our country improve dramatically. We would decrease suicides. We'd protect young people from going down this route. We'd protect from all the adverse events that are associated with these drugs. Now, we're talking specifically today about SSRIs. There are other drugs that can and should be used as tools in emergency situations. And yeah, I think being responsible with how to use those drugs, not over prescribing them, using them only in emergency situations, is something that does not happen in the United States. We prescribe multiple drugs. We polypharm drug our population. There are drug interactions that exist that create significant problems, crisis situations. Uh, Most crisis situations are going to incur when we start a drug, stop a drug, increase a dose, decrease a dose, add another drug. In our country, we're taking people off drugs really fast and inducing withdrawal symptoms. So there's a whole complex area of these drugs that are being prescribed by psychiatrists, and they're part and fueling the mental health epidemic that exists. So I can't put it into a binary form like one is better than the other. The primary treatment in mental health in this country is poor, and I argue that it's harmful.
Yes, I agree with, especially with the layering drugs. Like one drug doesn't work, so I'm going to try another one. Or you're getting symptoms, side effects from this one, so I'm going to give you another one to help you with it. I disagree with that. And I even remember my psychiatrist, the first line of help. As I said, it was my choice. Nobody helped me, so I chose. I remember when he said, because I had severe anxiety, I even went through panic attack. He gave me, I've never taken this in my life, a benzodiazepine. I don't need to say the name, but immediately he warned me about the medication. He said, be careful with this medication. It is addicting, and you only take it like when you're in crisis, where you're about to like faint or feel like you're going to have a heart attack, which I've had several of those episodes. So he warned me about that. So luckily, I don't have an addictive personality problem, but I can see how people can get addicted to that. And I always had that mind, like, be careful with this. This is dangerous. This is harmful. I would tell myself, about that. So that's something I feel like people have to watch out for, relying on that. And even though I have to say that I took it on several instances and actually saved my life, but that's another another episode where I had to take it just to kind of put my emotional regulation, which was up here when I was at my worst state, to bring me down here. And then I'm like, okay, now I feel better. I don't have those bad suicidal ideation. It saved my life. But it's still a dangerous drug. And I agree with you. That's even more dangerous than SSRIs. I have to say that.
Well, they're both dangerous under context. So both drugs create dependency.
Oh.
Benzodiazepines will create dependency
Hmm.
much faster, right?
Yes.
There's still going to be a withdrawal effect when you stop taking the drug or you take it for a long time. There's something called a rebound anxiety, right? You need more and more of the drug to provide the same result.
Mhm.
Again, context matters. Somebody being provided a benzodiazepine for a short period of time, maybe in a crisis event, may be a helpful tool. And I would argue that it might have greater value than any SSRI.
Mhm.
Using benzodiazepines as a treatment for sleep problems, using it as a treatment for panic disorder, giving it people for more than 2 weeks at a time, you know, then you're inducing drug dependency. It has
Mhm.
nothing to do with an addictive personality. It has to do with the physiological reaction to the drug and inducing dependency.
Yes. I definitely agree about that. And I was just saying, basing it on my experience at how that's not a good medication. And I was surprised when you said SSRIs are dependent forms dependency too. I mean, not that's different from being addicted, or is it the same? Like you're dependent on it, like you.
No, if there's physical dependency from SSRIs, and
Mhm.
and when people stop the abruptly stop the drug, it induces pretty severe withdrawal reactions. And when people are on the
Mhm.
drug for, there's people who can't get off the drug, Tanya.
Yes, I agree with you. I know, I know. I have
Yeah,
experience with it too. I have experience.
yeah, that's what physical dependency is. Like physical dependency starts very, very early. And yeah, I mean these are really important issues. Um, Doctors in the United States don't even know how to taper people off these drugs. And there's been protracted withdrawal syndromes that have taken place. And so like they're dangerous drugs that have potential really harmful effects. And people all over the country are having a hard time getting off these drugs. I mean, I come across people who've been on them for decades, right? I mean, they
Yes.
really, what happens? We don't have enough conversations about what happens when you start taking an SSRI. Well, there's certainly like these down regulation effects. Right? The brain senses that it's abnormal to increase serotonin, and there's several ways it attempts to reverse it. One of those ways is it compensates and responds by defensively destroying its own receptors for serotonin. And so it's fundamentally stopping something that is natural in the body. And now you are the irony of all this is when you take the drugs, you are inducing a chemical imbalance. You're not correcting one, you're inducing one.
Hmm, interesting. And I've heard of also of serotonin syndrome. Have you
Of
heard of
course.
that? That's
Yeah.
I
Yeah,
don't
of
know if it's
course.
like too much serotonin, too high, milligram dosages of the medication can cause that
Of course.
with adverse reactions. And so, what do you recommend? Like for instance, as you know, that I've been through the clinical depression, and I didn't see myself as broken, but I understood. And you also say it's not an illness, but for some reason, when I was going through it, and it was pretty intense, it was debilitating for me. It was like the worst imaginable. I'm probably one of the worst cases, with the suicidal ideation and attempt and hospitalization. But when I realized it was an illness, and I know you say it's not an illness, but that was somehow a turning point for me by me saying, this is an illness. This is something that's not temporary. It's not like, oh, I just lost a job or I just had a broke up with someone. Or it was like debilitating in a way where I was willing to try anything to get better. And I chose to look at it as an illness. But why do you say that? No, it's not an illness. But why did that? I guess I'm trying to say is that helped me recognizing to work on getting better.
Well, some of these are semantics, so you'd have to define for me what you mean by illness.
Illness means that there is something extremely strong going through mentally and physically through the body, where you're getting aches, your emotional regulation, it's very hard. You're just feeling helpless, worthless. Everything is going wrong with relationships, with work, with bad events. Just everything is just building up so much where you feel physically ill. I mean, I had aches in my bodies. I had insomnia. I mean, it's basically felt like any other illness, physically and mentally illness and bad thoughts, just everything. I mean, I can remember those situations very vividly, but luckily I did a lot to improve it. So, I mean,
Yeah.
I don't know. To me, it looked like, gosh, I looked like an ill person and felt like one.
Okay, so I mean
As
the way that
opposed
you
to today, I'm like, wow, I don't feel ill today. I feel like normal.
yeah, so back to the use of language. I think so you just described a series of symptoms or experiences that you felt that you feel it physically. I'm certainly not going to dispute that. It's just that most Americans don't define illness in that way. They see it as something that has inflicted them, that is outside of them, outside of their control. that must be treated externally. Like, so if I have the flu, I've been infected by a virus,
Hmm.
or if I have diabetes, I my body doesn't produce insulin, and I need to receive medical care. Generally speaking, you know, that's not traditionally how we've talked about diseases of despair. That's something that has inflicted someone from the outside, and then actually approaching that way mentally hasn't improved recovery rates, it's decreased it. So maybe for you to use that word, it helped you. I'd have to spend more time in understanding what that actually means. When I don't say it, when I say it's when I don't use the word illness, it's not discounting the severity of it, or that the person requires help. It's nothing of that. Um, it's just being able to speak to what we've done as far as medicalizing so much of the human experience, and what are the consequences of doing that. Now, there are some real medical conditions that induce that exact reaction that you just described,
Hmm.
that we miss because we see it as a psychiatric illness. And I think that's a tragedy, obviously. So earlier you mentioned, you tried to compare depression and like endocrine disorders, like thyroid conditions. And I said that's a false comparison, because you can go into a doctor, you can test that you have hypothyroidism or hyperthyroidism. And we know that there's a medical condition that we can evaluate, treat, and then you can retest. That doesn't happen physically with depression. You don't go in and get a test of a blood test or a chemical imbalance and say you've been inflicted with this illness. It's condition where the person has the power and ability to overcome it with their own mind, their own behavior, their own actions, their own attitude. So that separates it from that physical condition. And I don't even say that just because somebody has hypothyroidism, it doesn't mean that there's not even other underlying health abnormalities that have created that type of symptom, right? So we don't call that clinical depression when someone is depressed because of hypothyroidism. We call it hypothyroidism, or whatever that underlying health condition is, because it needs to be treated medically. We don't have those treatments in depression. You're giving a pill to trying to induce a change in their consciousness. You're trying to numb them out. You're trying to induce a health effect. So I don't see that as the approach, and I think there's tons of evidence to support that. Just like I wouldn't see alcohol as our primary treatment for social anxiety, nor do I call social anxiety an illness. Right? There's a
Oh,
whole
no.
ranges of experiences and reactions, right? So you say, no,
Hmm.
no, I'm not going to call social anxiety an illness. Well, why would you
No.
differentiate and call, depression an illness when someone can experience the same debilitating effect from social anxiety?
Okay, yeah, that's an interesting question. I guess I'm looking at it as you're comparing yourself before you've had it and after. Like you're like, okay, I was an able functioning human being. I was able to handle my anger. I didn't have crying spells. I didn't have triggers. I was able to go to work. I didn't have all these negative thoughts. I didn't have suicidal ideation. I didn't have bad events happening to me. I was able to handle stressors during the day without medication, without therapy, without anything. And then all of a sudden, I got this condition where, gosh, it's harder for me to get out of bed. Oh my gosh, why am I having insomnia all of a sudden? Oh, my eating patterns have changed. Why am I having these outbursts or these bad thoughts? Why am I having a harder time dealing with people? Like everything dynamic uh, has changed. Why am I getting more aches in my body? Why does it just seems like just horrible to even wake up and just face anything? I don't know. To me, I know. I know what you're trying to say. It's not a good name to put through it. Illness, a condition. Maybe you can say a condition.
Yeah, to me, it's semantics, and it doesn't really matter.
Yes.
What I'm concerned about is that there is a sect in our culture that describes it as a biological illness, and they inaccurately describe it that way or treat it that way. I mean, I see it in my community all the time. Um, although there's the chemical imbalance myth of serotonin and depression has been debunked, it's still believed by a large portion of the American public. And they believe it because it's also still communicated in our healthcare centers.
Hmm.
And
And
there's
okay.
There was also a belief that it would decrease stigma of mental health conditions if we discussed them as like biological illnesses or we used medical terms for it. And the opposite has been true. There's no evidence that it decreases stigma. But what it certainly does is it increases the amount of people who will identify that way and seek out medical help.
Okay, and I'm just like wondering. Okay, yeah. So, but SSRIs, there's another kind. I think it's SNRI. Is that what it is? That's more of a dopamine, releases more dopamine as opposed to the serotonin as an antidepressant.
It's targeting serotonin and norepinephrine.
Yes, that is. And because I know, I believe in certain types like SNRI, and as you said, it depends on the reaction with somebody's body and their chemistry. Like for instance, I tried that temporarily. Luckily, it was 2 months, and it didn't work well for me. It was horrible. Actually, not to name any medications, but that is the one that put me to hospitalization because I realized because supporting your beliefs of how it can make somebody worse. So I agree with you on that. I believe that medication did make me worse and was the cause of the hospitalization because I felt like maybe the dopamine levels, it was just shooting too much. And for somebody that was already going through a lot of emotions and putting them more on edge. So, in that respect, like supporting medication that can make one worse, that did make me worse. But it was the SNRI, not the SSRI. So, the SSRI actually had the opposite effect. So, I don't know what you know about the SNRIs. I just kind of threw that in there too, that type of medication.
Is our question?
Oh, yes, yes. What do you think about the SNRIs? I know you're an expert in the SSRIs as far as people taking those and how it's impacted them or making them worse
Yeah, as I mentioned
or
earlier,
better.
targeting specific brain chemicals for a drug effect has had dire consequences. I don't
Mhm.
call them as medicine, I call them as drugs. And I think it's an experiment on the brain that has proven to have detrimental effects where people are not provided the accurate information of it. So, yes, like drug effects are going to have drug effects. People experience those differently. Um, they're trying to change the way a person thinks and feels in the short term. And I don't support that approach for the conditions in which those drugs are prescribed, which are generally in the anxiety, depression spectrum.
Okay, good. So, yes, I understand that. So, getting away from medication now, just talking as a clinical psychologist. So we know that your mental health is influenced by your biological, psychological, and social factors. And I know you briefly talked about that earlier. Can you explain how these elements interact in real life scenarios and how they can help somebody who is struggling with their mental health issues apart from medication?
Yeah, sure. Well, I think it's really important that we communicate emotions as energy. They're evolutionarily adaptive. We feel them for a reason. And they're usually good indicators that there's something the matter with us, right? There's something wrong when we experience negative emotions. We're supposed to use those to our advantage. So usually they're kind of our body's alert system. We feel fear or anxiety when either the mind or real situations create scenarios that, hey, we should watch out. We should be vigilant for. We could be in danger. You could see they're evolutionarily adaptive. We feel sadness and loneliness when we're isolated and we don't feel connected to people around us. And so we have to improve the emotional literacy in our country to understand that they're sending a message to us. We don't want to look at them as symptoms of an illness, or we don't want to say that there's something inherently broken within us. The fact that you feel them means that there's something going on that you have to face. Now, the range in which people respond to their emotional states varies greatly. There's something called avoidant copers, people who uh, are scared of their own emotional states, try not to think or feel. They suppress or repress emotions. Maybe they're more vulnerable to escaping situations, or they lack assertiveness and problem solving skills. Maybe they turn to drugs, alcohol, or eating disorders as a way of numbing or disconnecting. So there's a lot of harmful ways that people can respond to their own internal states. And we know what effective therapies or treatments really are about having that people kind of understand when those emotions were provoked, how they're coping with it, to face and solve the problems and move through it, to see it as episodic. These conditions are should be episodic and not chronic. Now, speaking to the biological and social factors and the spiritual factors, right? There's all reasons why we might not feel well. If you put somebody addicted to a phone under um, under conditions in their life where they're, isolated, working in a office, for example, with fluorescent lighting, they don't have enough exercise, connection to nature, light exposure.
Mhm.
It can impair their circadian biology in so many different ways. You eat unhealthy
Exactly.
processed food, your exposure to chemicals, toxins, all these situations affect our physical well-being. And there's
Absolutely.
obviously,
Hmm.
again, our emotions are tied. They're there to serve us. So when we're sick, we feel horrible, right? And then those
Hmm.
in our sick care system, we just drug the symptoms and we're not dealing with the underlying causes. We know metabolic illness is certainly a driver of low mood and fatigue and insomnia and a number of other things. Again, my problem is that we just label those as psychiatric and we're not dealing with the
Hmm.
core root issues that are influencing somebody to feel that way. And integrated and effective treatment is seeing the whole person, right? Seeing about their
Hmm.
environment, the way they cope, the way they live, their behaviors. You can really help people change behaviors that can have a downstream effect. When someone's able to
Absolutely.
sleep, what a difference that has on their
Oh,
mood.
yeah.
If you
Hmm.
get out of a horrible relationship, for example, that can
Hmm.
be life changing for them. If they meet somebody new, or they change a job, or they start exercising, or they make these
Hmm.
real changes, obviously the effect of that is powerful on mood. And so that's why I think I take a more common sense and practical approach, which I think is also science based, is that we have to get back to treating what are the root causes and not make up things that just serve an industry, especially a pharmaceutical one.
No, absolutely. I 100% agree with you. Again, based on experience, when initially I didn't know what to do or who to turn to, and then not unfortunately or fortunately, my first step was going to a psychiatrist, getting an SSRI. I can't believe it took me so long to connect with a therapist. Nobody helped me. Nobody told me. I had to do all this information search on my own. Let's see, I saw him for 2.5, maybe 3 years. It took me 3 years and a hospitalization for a suicide attempt for somebody to finally tell me you need to work with everything that you shared with a therapist in order to get your life in order and your thoughts in order. I mean, she was a game changer. I mean, I had to go through all of that for somebody to say, like, hey, psychiatrist isn't enough. No, this medication stuff is not enough. That's not going to, well, I mean, I already knew that's not, I was trying to help myself. I was trying to be my own therapist. But that was a game changer when I actually found someone and I was able to see her or talk to her once a month. I mean, she helped me immensely other than medicate as far as I mean, I helped myself changing eating habits, less processed food. I did that. Less processed food, introducing more fruits and vegetables. I did that. Exercising, even though it was such a pain in the beginning, I could barely move more than 10 minutes because I had, like frozen shoulder, all these body aches. And I kept pushing myself, oh, just 10 minutes. That's all you need to start with. Now I'm up to like 45 minutes walking in nature, getting nature. Fluorescent light is awful. I used to work in an office with fluorescent light, being trapped under that fluorescent and no window, fluorescent light, felt like it was a toxic work environment, trapped. I started getting claustrophobia with the depression. I'm like, oh my God, I can't stay in this like confined fluorescent because it was making it worse, the depression. Definitely fluorescent light. So those are the things I had to change, just like what you mentioned. I was like, okay, I need to change these in order to get better. Insomnia, I just kind of dealt with. I was like, just get 4 hours of sleep and deal with it because nothing was working. But eventually it got better on its own after like 2 to 3 years of just struggling with sleep. And I just told myself to deal with it. Like, if you have to get 3 hours of sleep, too bad, just wake up and go to work. So I was going through that until finally it worked itself out after going through the depression and working on it. So I agree with you, all those things you mentioned, because when I was adding those into my life, it was making me better. And yeah, so I agree. I don't know if there was anything else that you wanted to add.
Yeah, I think it's just a reflection on, what I said earlier is that we can also see struggles in our life as opportunities,
Hmm.
opportunities for needed change, right? To get our health back in order, to get our relationships back in order, to see life differently. And you know, I think when we think about it as an illness and we talk about it in that way and we externalize the treatment like someone's going to do something for us, I think it gets in the way of us seeing this as our own opportunity for transformation. And part of this is just the
Hmm.
cultural lexicon. I mean, so many people continue to talk about this in terms of a brain disease. And even when you go into schools, I mean, my own daughter was told in her health class that if you ever suffer depression, it's related to low serotonin and you need to go see a
Oh,
medical professional, right? And so
mm,
this is how these
that's
myths,
not good.
yeah, this is how these myths continue to become discussed. I mean, you repeat lies long enough, it becomes a collective truth. And
Hmm.
I think it's part of my responsibility is just to be open about what is true and what is not true, and you really respect people's ability to make informed decisions when they're provided all the information.
No, absolutely. I mean, that's just misinforming someone to say, "Oh, your depression is because of a low serotonin." I mean, I'm sorry, I absolutely disagree. You have to get to the root of the problem. You've had issues in your life, whatever those are, you've got to face them, no matter how hard. I mean, I believe that I had to face whatever the hard events and issues on my own too. It wasn't like, oh, the pill, help this go away. No, it's not. I basically already knew that I had to do the work myself. And a lot of it that I did, or what people have to realize is they have to do the work, no matter how painful. There's only so much a pill or a therapist can help you. Most of the time, you're on your own, and you have to work with strategies that'll help you. And if you had to, in your experience, what is it, one type of therapy that you feel like there's promise and truly helping? Is there a certain type in their lives for depression?
Well, I don't like to talk about just like a label or a name
Yeah.
because that just like fits what ends up being this almost like this ideological adherence to the name of a therapy. Like, and so in psychology, right, there's like psychodynamic therapies, cognitive
Mm-hmm.
behavioral therapies, cognitive behavioral acceptance and commitment, all these type of treatment packages. Instead, it's like important to say that what are some core principles in treatment of depression? What do we know from good scientific research? And how does that best inform clinicians to work with somebody? So instead, I'd like to talk about it in terms of, what are some of the most effective interventions that are proven by research. Many of them come under an umbrella of cognitive behavioral therapies because that's an umbrella term. So behavioral activation being one of them, it's getting people moving again,
Mm-hmm.
move a muscle, change your thought, change your experience. But it's also understanding that there are multiple root causes for somebody who is feeling that way. And we have to understand why they are in context. And we have to support and influence people to change their life, right? To actively change their life. That might require new skill development. That might require like behavioral scheduling. That might be supporting and working with someone to face problems or painful memories. So I've worked with people who've been depressed their entire life. I've never met the same person twice. Everyone's different. So
Yes.
therefore, the treatment looks different based on who that individual is and what they're going through.
Okay, great. I mean, I want to again tell you, like, thank you so much for being here. You shared such valuable information, and I really appreciate it, Dr. McFillin. Thank you
Thank you.
for being here.